Welcome, everybody, to today's episode of Diversion Insights. My guest today is Stacy Hershman. Stacy was, until recently, a Diversion analyst, and I'm going to ask Stacy to share her background with you, which really puts her in a unique position as a Diversion analyst. But today, our podcast is going to look at some things that Stacy has encountered in her work as an analyst, as well as some trends that she has noted for those clients that she's had. So first, welcome, Stacy. Thank you for being here today. And just share with the listeners what your background is.
Thank you for having me, Terry. So I have a lot of pharmacy tech experience, about 15 years as a pharmacy tech. And of course, I did pretty much every role there. I was in the IV room, the narcotic vault. So I put a lot of time in the pharmacy and restocking devices, the Omnicells and Pyxis. And then I also worked as a critical care nurse for 4 years. And I went to a drug diversion analyst role.
Okay. All right. So pharmacy technician, 15 years. That's a lot of years. And you transitioned into nursing. Was nursing something you knew that you always wanted to end up in? Or were you kind of motivated working in the hospital and interacting with nurses? How did that happen?
I just have compassion, and I feel like it's missing a little bit in healthcare. I just like to take care of people. And the opportunity arose for me to go to nursing school, so I took it.
Okay. All right. That's great. So great pharmacy and nursing background. Now, you don't find that very often to put together, and that's the perfect combination for a diversion analyst. Let me ask you, overall, before people implement a monitoring program, whether it's with software or not, but certainly with software, because we see so much more with software than we do with the more manual programs, is there one main piece of advice that you would give hospitals?
To clean up the bad practice prior to implementing the software system, because it's going to give you a lot of noise, and it's really hard to hone in on diversion.
Okay, I agree with that 100%. There's a lot that you start to see that you never knew before. One of the biggest things, I think, is unaccounted for controlled substances. I think, people are often shocked when they see how many whole or partial doses are just missing because nobody charted it as administered, or nobody wasted it when wasted it. And of course, that could be diversion, but it also could just be a lack of accountability. So you really don't know, but it just does muddy the waters. Are there other kinds of poor practice trends that you see that need to be cleaned up that you would recommend addressing?
The biggest one is wasting PRN doses as refused by patient, because as a nurse, you know that you should be assessing your patient and having that discussion prior to pulling the medication. But oftentimes they just get in a funk and they just go pull all PRNs and give it to the patient. And then when they bring it, open it, and the patient refuses it. So then they waste it, which is a big place where it would be easily diverted, like an easy diversion.
Sure.
So I have seen that across, different facilities, and it just seems to be a big one that needs to be educated on.
Yeah. So let me ask you about that. I mean, we do see that. How often is it possible that a nurse may assess the patient? They say, yes, I want it. They go and they remove it. They come back into the room. They open the packaging. And then the patient then changes their mind. I mean, I imagine that can happen.
It does happen. I've had it happen to me. You bring it in, you already had the discussion. Their pain was a 7, so you're going to give them oxy. So you tell them you're going to go get the oxycodone. And then when you come back in, they say, well, actually, I have a headache. I would prefer Tylenol because the oxy doesn't touch my headache. I've had that happen. But my practice is I will talk to my patient again. I scan their wristband, ask them their name and date of birth. And then I will tell them, okay, I'm going to give you your oxycodone. So before I open it, I tell them I'm giving it to them and if they're ready to take it. And then I scan it and then give it. But if that's an opportunity that I could return it if they change their mind.
Yeah, that's what I often wonder too. It's like, okay, well, if they refused it, then why didn't you return it? There's one to not assess, and then there's two to open it before they refuse it. So I like that. So you're kind of essentially assessing them twice. It's like you're assessing, and then you're like giving them warning. Okay, I'm going to give it now. And I like that. So that really should take care of just about everything, unless you're wasting. If it's a partial dose and you waste at the time of removal from the ADM, then you would have already opened it.
Correct.
Okay. All right. Any other types of practices that you see consistently that may or may not be diversion, but it's certainly at the very least a practice that should be cleaned up?
One thing is pain scores. Oftentimes, sometimes they're not even documented. Sometimes they are. There is ways to help an organization make sure they're getting documented by like their order sets to make sure that oxycodone has where they have to put a score in before they can administer. So there is different things that you can do to help with that. Regulatory agencies are always looking at that when they come in to evaluate your hospital to see where you are. They always ding nursing on with a parameter for the pain medication. So, like if my patient said they had a pain score of 3 and I gave them an oxy and it was for 7 to 10, you would get dinged on that. So it's definitely important to look at those pain scores.
Yeah, and even there's a lot of failure to document a pain score. I notice that a lot. And so that is a regulatory thing. And I have been in institutions where they've been, nailed for that. And had to implement this entire action plan where now they have to check it. It's a lot of work, right? You institute these action plans. It's a lot of hours, and the nurse managers need to now do this and check their report and deal with it. So it is a big thing from a regulatory perspective, but it's also frustrating, I know, for me when I'm doing an audit. And I think I, may have somebody that I'm suspecting. And so I want to see how that patient has responded to those meds prior when other nurses have taken care of them. And then those nurses aren't putting enough of a pre or a post. In that case, I want to see the post, how they're responding. And it's not there. And so it's not just the nurse that I am looking at. The others aren't helping me in this situation because I can't see the trend of what, the patient, how they have responded to that medication when other nurses give it. So there's lots of different layers to that.
Correct. And they, so with that, like most hospitals have it in their policies and procedures of how soon they have to reassess the pain.
Sure.
Most is like 30 minutes because that's when you're going to see if they need it. And if they're truly in pain, they are going to be on that call bell. Some other bad practice things that I see is holding meds. So pulling the med, but not giving it in a timely manner. Most hospitals want controlled substances to be given within 30 minutes. And if they're holding it longer than that, you ask several questions. Where are you storing it? Why you're waiting? So that's one of those things that needs to be educated and make sure it's an expectation that is set with the organization as well.
Right. Yeah. So as a nurse, let me ask you again, what does a nurse typically do between the time they've assessed their patient, they go to the machine, they remove the med, and then you do see, let's say 30 minutes in between? Which, I mean, I would prefer to see the time it takes you to walk down the hall, right? So whatever that is, 5 minutes, 6 minutes, have that conversation, and scan it. But if a nurse is holding on to it for even, say, 30 minutes, what is the delay in between there? I mean, obviously there's emergencies and somebody else could ring the call bell, and maybe this is the answer. They're maybe I need to use the bathroom, and you've just pulled something for somebody else. Should those be the exceptions rather than the rule?
Yeah, there is exceptions to it because, I mean, there's rarely any times that I can get to the device without seeing a call bell. Like if you're on a med surge floor, there's always something going on. There's a chair alarm going off, a bed alarm going off. There's just a lot of things. So a med surge floor, I'm a little bit more lenient with the times than like an ICU. Yes, there's emergencies in the ICU, but you have less patients, and a lot of them aren't on their call bell, hitting the call bell and requesting different things. So there is exceptions to the rule, but it's, looking at the overall picture. How many times have they held on to this? And why are they pulling it early? Like a PRN medication, if a patient is truly in pain and they're requesting oxycodone, hydromorphone, they're going to be on their call bell within 5 minutes asking where it is, in my experience.
Okay, interesting. All right. So that's good to look at. The hospital may have a policy that you have to administer it within 30 minutes or 60 minutes. I've seen sometimes, but you would expect, especially on a med surg floor, if I'm hearing you correctly, that there shouldn't be much of a, I'm just going to throw out 10 minutes because you got to get down the hall and have a conversation with the patient and scan it. So if a nurse is routinely taking longer than 10-ish minutes, even though they're falling in the policy, then it's possible that you may want to ask the question, like, why does it always take you 20 minutes? Like you're consistently 20, 30 minutes, even though they're following the policy.
Correct.
As opposed to ICU, where your patients are sicker and not necessarily calling you. They might be on, ventilator or what have you. They're not communicating. And so you go and you do. So that should be a much shorter, typically, unless there's been an emergency on the unit as a rapid response or something like that takes you from where you need to be.
Correct.
Okay. All right. Yeah, that's good insight. Because as a nurse, so there are times when, it's like, well, is there, what's going on with this workflow in this area that could explain this?
Yes.
And sometimes I don't even know what kind of latitude to get for like patient refuse. It's like, well, okay, did you check with them? I guess they could change their mind.
Yes, but when it happens more frequently than not, it's either really bad practice and that's what other people are doing, and then, or, it's potential diversion.
Right. Okay. That makes sense. In your experience, when you find someone that looks suspicious, you're looking at the data and you then disseminate that information out to the facility, what percentage of the time do you feel that they follow through adequately on what you've given them?
It really depends on the facility. There's some facilities that are really great at responding, so they have like a 98%. And then there's others that, send it to the nurse manager and kind of just drop it. And they accept like vague responses. Nurse was busy, or, just simple statements that they return back. So I would say probably about 50-50 of facilities that were really great at responding to what I sent them versus others.
Okay. So then I guess the question, and maybe you don't know if you're not on site and you don't get a feel for that, is that, do you have a feel for, is it because they don't have a developed program? They may have software, but they don't have a developed diversion program. Is it a culture thing where leadership, even though they would look like they have a developed program, it still ends up, oh, it says poor practice because of the culture or leadership buy-in? Do you have a feel for?
Yes, I did have a few hospitals that were cultural for sure. They didn't think that diversion would happen at theirs, and they just said it's bad practice all the time. And others don't have a developed program because, diversion is always changing. And I think it's getting a lot more spotlight on it than it has in the past. So they don't know where to start. So it's easy to, help give them resources to build a strong foundation.
Right.
In their diversion program.
Yeah, that makes sense. I'm a huge advocate for having a champion for the program too. Are there cases in facilities where you feel like it's lacking that champion?
I think so. I definitely think some facilities need like more FTEs, to help.
Sure.
Because if you have one person and there's like 1,000 bed facility, there's no way that they're going to be able to, go through what I send them.
Right. Yeah, that makes sense. Okay. What piece of advice would you give a new diversion analyst just starting out, doesn't really have any experience, has software at their fingertips? One piece of advice for them.
So if you're using a software system that you're having like alerts generated, my piece of advice is to look at transactions around what you're actually what actually flagged in the system, because it tells a big picture sometimes. When you look and you see the same nurse's name multiple times and you don't see hardly any other nurse's name pulling the same medication, that's red flags to me.
Okay. All right. Is there, I'm going to put you on the spot, so if you can't answer this or come up with something, just let me know. Is there one case in particular that you stands out in your mind that like blew your mind or surprised you or went a different direction? Something that you've seen that you could share.
It was actually my first confirmed diversion case as an analyst. Of course, that's going to stick with me. She was accessing PRN medications prior to their schedule. So it was Q4, that particular hospital, you could only remove 30 minutes prior to the next dose. So she was taken out at like the 2-hour mark, and then she was wasting as refused by patient.
Got it. Okay.
So,
and was it the same drug consistently?
Yeah, so it was the same drug. It was oxycodone. And when you looked at the patient level and you just seen her name, and you've seen no other names. And so you're like, okay, well, this patient had this much pain during day shift. What about night shift? Did they not have pain? Because, and then you're wasting as refused by patient. And that's what keyed me into her, just seeing her pull all those extra meds and wasting them. And so if I just look at the one, what is it?
Go ahead.
If there was multiple nurses, well, I don't know what I was saying. Never mind. Go ahead.
Yeah, no, I would say if only they were all that easy, right? That one, she's pulling it out before it's due. She's wasting it, saying it's refused. It's the same med every single time. Those are the ones that, are pretty clear. When people ask me, there's different buckets you put them in, right? There's now I don't think anything is going on, to the more common is, there's a few things here. I can't really tell you for sure whether it's practice or diversion, but there's enough to have a conversation with. And this is where I find many facilities don't have the conversation. They just go straight to the assumption that it's just practice. And then there are the ones that are more, okay, I can't imagine what their answer is going to be to these questions that would exonerate them. I think we have a problem. Even before we talk to them, it seems pretty clear. So those to me are those three major buckets that things go in. Unfortunately, most of them are in the middle ones. Yeah. Okay. All right. Well, thank you very much for spending time with me today. And I know you're no longer doing diversion analyst stuff. You've moved on into more of a IT type of a role. So I hope that you are enjoying that. I'm sure that there's probably a lot that you can take, I'm sure, from your pharmacy, your nursing, and your diversion analysts and apply that to more of an IT role. I think they probably get a lot of different kinds of insight from based on all those experiences. So I hope you're enjoying what you're doing.
Yes, it's been good.
Good. All right. Well, thank you very much for spending this time with us, Stacy.
All right. Thank you.